Hi, Facebook Live. Welcome. This is Dr. Bill Bird. I'm the Chief Medical Officer at CGH Medical Center. Glad you could join us for our broadcast today. And I am joined today by Ashley Swanson. Ashley is the director of our Respiratory Therapy Department. Hi, Ashley.
Hi, Dr. Bird.
Great to have you on today.
Thank you.
I sprung this on Ashley, I think Monday, didn't I, Ashley?
Yes.
Yes, and I didn't want to make you too nervous for too long, right?
Yeah, I appreciate that.
We were saying before the broadcast, this is a study in contrast with my pasty white look, and then Ash looks, she definitely has much more of the on-camera look than I do, that's for sure. So welcome, Ashley.
Thank you.
So respiratory therapy. I think sometimes people get in their minds doctors and nurses, and there's another beyond just respiratory therapy. There's other folks too, but respiratory therapy is a big part of taking care of COVID patients here at CGH and everywhere. Can you describe to our listeners what role your role is in taking care of our COVID patients here at CGH, Ashley?
Yeah, absolutely. So our COVID patients, respiratory therapists, we support our patients' breathing, and we do that in various ways. We could be at the bedside giving a meter dose inhaler to a patient or a nebulizer. We also support their oxygen needs, whatever that may be. We provide them with a heated high flow nasal cannula if they need it, a BiPAP machine, and occasionally a ventilator. And for our patients that get to go home, we also are very active in setting them up with nebulizers for at home or oxygen for at home.
Right. Before we go any further, Ashley, I just want to, for the folks who are listening, as we always do, I encourage you to send shoot a text to us, and we'll try our best to answer any questions, particularly while you have Ashley here, anything regarding respiratory therapy. And what we're going to do, like we usually do, is when I get done chatting with Ashley, then I know we have some questions from our viewers already, and I will definitely answer those when I get done chatting with Ashley. So I want to let you know that too. So Ashley, one of the things you alluded to, you said the word BiPAP. There are a lot of different ways that we help patients breathe here at the hospital, actually that you help them breathe here at the hospital. Can you kind of talk through the sequence of, the nasal cannula, heated high flow, BiPAP, ventilators? What exactly does that mean for the lay person?
Yeah, so I actually have a nasal cannula here.
You're going to put it on?
I don't know. I'll just show you guys.
Okay.
So this is what a low flow nasal cannula looks like, and it just sits right at the patient's nares, okay? So this is what a lot of patients will wear at home if they have home oxygen, and we can provide 1 to 6 liters of oxygen with this.
Okay.
Now, if our patient doesn't tolerate this, especially our COVID patients, then we can move up to a higher flow cannula. And I have that here. And this is a high flow cannula. It's a little bit bigger if you can tell the difference between these two things. It's a little bit bigger.
Yeah.
So we can provide up to 15 liters of oxygen with this cannula.
Okay.
So then if our patients aren't really tolerating that and they need something more, we would advance to what we call our heated high flow nasal cannula. And I think Matt has a picture of that. So this is our heated high flow setup. And what this does is we are able to give patients anywhere from 21% oxygen, which is the oxygen in the air that we all breathe. So Dr. Bird and I, we're breathing about 21% oxygen right now. So with the heated high flow cannula, we're able to give a patient 21% oxygen all the way up to 100% oxygen with this. And this actually it sits in their ears too. So their mouth is open and it's just a cannula that we put right in their nose, and we're able to deliver all that oxygen to the patient. In addition to that, we can also set a flow rate and the flow can be anywhere from 20 liters all the way up to 60 liters. So what that flow does is it helps just to kind of stent the airways open a little bit more for the patients, so that hopefully we don't have to give them as much oxygen. Some patients just need a little bit
Yeah.
more flow.
Yeah. Okay. And then is the next ratchet up from that the BiPAP? Is
Yeah.
that okay?
Yep. So then
Uh,
So then we go then to the BiPAP machine, and the BiPAP machine is
thanks, Deb, by the way. I appreciate that comment.
this BiPAP machine then is a mask that we would put on the patient, and it goes over their nose and around their mouth, and we're able to set certain pressures with this to assist the patient's breathing. And again, we can give them 21 to 100% oxygen with this as well.
Yeah. And the BiPAP is more of a seal. You're like you have something sealed on your face, which is putting that positive pressure to kind of keep your airway open. Is that right?
Correct. Yep.
Okay.
That's exactly how that works.
Okay.
So
And
then
go ahead, Ashley. I'm sorry.
I was just going to say then if this isn't tolerated, then our next step would be the ventilator.
Yeah. So would you say of of our sick patients, what do they tend to be on if they get up into the ICU?
So a lot of our patients will end up on the BiPAP machine. They will go from heated high flow to the BiPAP machine, and then we try to give them breaks if we can from the BiPAP and put them on the heated high flow if they can tolerate it. But generally, they go back on the BiPAP machine to help take away that shortness of breath.
Because that pressure, that extra pressure, kind of opens their lungs a little bit better than just a bunch of oxygen.
Yes.
Yeah.
Mhm.
I haven't even thought about this, but I bet you we've gone through a lot of oxygen.
Yeah, that's
Yes.
what I hear, and it's not a surprise to me. We've been running a lot of
Yeah.
equipment.
Yeah, for sure. So, okay, so that's kind of the different options we have to treat patients in terms of helping them to get more oxygen and support them as as their body tries to heal up from this infection. I want to talk a little bit about one of the things that we've done to try to the kind of the balance between what's Melissa have to say. Yeah, yeah, thanks, Melissa. Yeah, we appreciate Northern Illinois Home Supply as well. So yeah, you guys do good work. So anyhow, what was I saying? Oh yeah, so one of the things with kind of the lines we're trying to balance is giving patients what they need for sure for breathing, but also making sure that we don't have as much. We don't want tons of aerosolization because of aerosolization makes COVID spread more. It gets more of it in the air. So could you talk a little bit about what we're doing at the hospital in terms of nebulizers, which are kind of that, if you've ever seen someone who has like you're getting their Ventolin inhaler and they have it up against their face in some way like that, and how we're doing nebulizers versus the puffers, the metered dose inhalers that you'll see folks do out in the community. How are we navigating that, Ashley?
Yeah, so since nebulizers can cause that aerosolization of particles and of the virus, we are going ahead and changing our patients to meter dose inhalers. So we're not giving them nebulizers as often, and instead we're giving them their breathing medications as a meter dose inhaler to help prevent the spread of those particles in the air.
How's that work? How's that going for the most part, Ashley? Because it's a change from what you guys are used to doing.
Yeah, we're used to giving nebulizers, but for the most part, our patients are tolerating it very well.
Yeah.
It's just a change in practice for us in the respiratory world.
Do you think that'll, like, once the pandemic's over, do you think we'll continue doing this? I mean, do you think that the pandemic is going to cause us to rethink how we do nebulizers versus inhalers?
I think so. I do. I don't know if I don't know if we'll actually go back to doing as many nebulizers as we have in the past.
Yeah.
Mhm.
Okay. Yeah. I'm. What would you say? Okay. How many on the ventilator right now? How many events do you have? Hi, Vicky. Yeah. So right now, I think we're doing pretty well in terms of not using a lot of ventilators at all. So we're really happy about that. How many ventilators do we have, Ashley?
Right now we have 5 of our own, and then we did get 4 from IDPH. So we have
There's a picture of one. There you
Yep.
go.
So we
Okay.
have 9, and then actually tomorrow we're going to take delivery on 5 brand new ventilators that we were able to purchase.
Yeah. And when we say that, Ashley, are we going to go up to 14? Or are we going to just trade out the 5 older ones for those 5 newer ones?
We're going to go ahead and go up to 14. We're going to keep our old machines and
Okay.
in addition to our new machines.
Okay. Yeah. Well, we should be amply supplied with ventilators, and I hope we don't need to use many at all. But that's great.
Yeah.
Question about what does COVID do to breathing, and why do patients need these machines? You want to talk about that a little bit, Ashley?
Sure. So COVID, for the patients that end up needing a BiPAP machine or a ventilator, generally what happens is they go into what's called ARDS, and that's where the lungs kind of get stiff and they're hard to oxygenate these patients. So that's why they need the extra pressures from the machines in order to help them breathe, basically.
Yeah. So our lungs have these little sacs called alveoli, and in the process of ARDS, or if you're having some type of injury to your lungs, those alveoli, and the alveoli is where, like, when we breathe in oxygen, it goes across that little real thin membrane there in the alveoli into your bloodstream. And during an infection like this, that exchange of oxygen into your bloodstream just doesn't happen as well. And so all these things that Ashley's talking about are ways to try to artificially increase the oxygen level that you take in so more can get across into your blood, or give more pressure so more can get across into your blood. Yeah, you're just trying to trick your trick your lungs, which are struggling, into getting more oxygen to your body. That sound fair, Ashley?
Yes.
Okay. All right. So what have been your team's biggest challenges in trying to take care of patients with COVID here at the hospital?
Yeah, so we have a couple of them. One is, at times our patient volumes. We have a lot of sick patients requiring these machines at times, and that's really been um, a bit of a struggle having so many critical patients. But then also, it's tough for the respiratory staff here at CGH because if you've ever been a patient of ours, we really bring you kind of into our family. If you're our patient, you're our family member.
Right.
And so it's hard for us in the respiratory department to see our patient, to see our family member struggling and trying to overcome this illness.
Yeah. And it's a struggle that, yeah, it doesn't always work out. I mean, oftentimes, fortunately, people do get better and go home, but
Right.
a much higher percentage of folks who have COVID don't do well as
Right.
compared to your typical flu.
Yes.
Yeah. Which brings up, I was just looking up these stats, and we were talking about these stats before we got on the air today. Our county death total is 85 right now, which is a very sobering number. And all those deaths didn't occur here at the hospital, but yeah, there have been way more deaths than we would like to have. That's for sure. Within the county, the math on that is, I think there's 55,000 residents in Whiteside County, so you're probably talking 1 in 700 of us have passed away from COVID since this pandemic began. So very sobering in terms of news. And Ashley's team definitely is, boy, they are on the front line in terms of experiencing and suffering in many ways with the patients. Yeah. So I wanted to ask you, Ashley, too. I mean, obviously you have other patients besides COVID patients that you're taking care of as well. What other kind of patients are you guys helping out with here at the hospital?
Yeah, as respiratory therapist, we take care of patients with COPD, asthma, to name a couple. But we also provide care in the nursery to newborns who are born maybe prematurely, or they are having just a little bit of trouble breathing, taking those first breaths. A respiratory therapist is there and helping assist them. We also are called to any code blue. So a code blue is when a patient's heart or breathing were to stop. So there's a respiratory therapist there to help with airway support during a code blue or any sort of trauma. And then we assist in all of the intubations for these patients. So if you need to be intubated and put on a ventilator, then a respiratory therapist is there assisting the physician or anesthesia to place that breathing tube. And then the other side of that is if you get to come off the ventilator, a respiratory therapist is the one taking that tube out for you so that you can breathe on your own. We also here at CGH assist in transports. So if a patient on a ventilator needs to be transported to another hospital by ambulance, there's a respiratory therapist that actually goes in the back of the ambulance with that patient to the other hospital.
Yeah. I hope for those of you who are listening, that you're keying in on the fact that, once again, I'm going to say it again. We tend to think, I read in the lay press a lot about doctors and nurses. Respiratory therapists are a big part of taking care of patients in a hospital, particularly patients obviously who have issues with oxygenation and respiratory issues. Yeah. So your team also has other things that you're involved with in terms of, for instance, your team oversees pulmonary rehab, pulmonary function testing, which is a kind of, you test to see how your lungs are working, whether you have asthma or emphysema or those type of things.
Mm-hmm.
Your team oversees the sleep center, both tests done here at the hospital and in the home. And if I remember right, your team oversees our EEGs, which are that brainwave test where you get hooked up with electrodes to see if you're having any evidence of brain activity or seizure activity. Is that a fair assessment, Ashley?
Yes.
Where are we at? Where's your team at in terms of, with the pandemic, what of those things are actually happening right now and what things are not?
So currently our pulmonary rehab department and our pulmonary function testing, they're closed right now. We've actually pulled those therapists from those duties to put them more in the acute setting so that they can help take care of our BiPAP patients and our ventilated patients. So those two areas are currently closed. Our sleep lab and EEGs are still open for business, just like normal.
Yeah. Okay. Yeah. So what we've done is you have flexed your department to cover these really sick patients, and you've had to kind of divert them from some of their normal duties.
Yes.
Yeah. And that's across our hospital. Folks have worked on that, and we've had to have some flexibility about where our folks are working, just because of, in some situations we had to be all hands on deck here in the hospital.
Yes.
To help out with these patients. And Ashley's team's done a really nice job with that. So Ashley, what's your story? How did you end up deciding that respiratory therapy was what you were going to make a career out of?
So now you know that I'm an emotional being, and you're probably going to make me cry here.
Oh, go for it.
So my grandmother, her name was Marietta Lilly. So
I knew Mary. Yeah.
You know Marietta, yes. So
Yeah.
she had COPD, and it unfortunately took her life. And see, I'm going to cry. And she's the reason why I'm a respiratory therapist. After she passed away, I decided, I wasn't able to help her, but I would love to have those tools and that knowledge to help other members in our community that are like her.
Yeah.
Yeah.
Yeah. Well, yeah, that's a good story.
Yeah.
Yeah. I knew Ashley's grandma and grandpa.
Yes.
I know some other family members who might even be watching right now. Hi,
Dad.
Anyhow, yeah, she was, yeah, I can understand that. I didn't know that, actually. I didn't know that was what kind of spurred you in the direction of respiratory therapy.
Yeah, I'm going to be honest. I had no idea what I wanted to do with my life. And I didn't even know that I wanted to be a respiratory therapist while she was so sick. It was at
Mm,
months after she had been gone. And I just thought to myself, wow, what am I doing?
yeah, yeah.
So
How long is the schooling to become a from the time you start to the time you're done and you're able to be a respiratory therapist?
it's a 2-year program, much like nursing, only you focus more on the cardiopulmonary system.
Yeah. Okay. 2 years.
Yeah.
And I'll tell you what, that is for those kids of you watching out there, or anyone I guess who's young at heart. Boy, at least in our area, we definitely seem like we have opportunities for respiratory therapists quite often. Just because you were telling me, Ashley, that most of the training, like in nursing, a lot of training happens locally, but for
Mhm.
respiratory therapy, a lot of that happens. Was it the Rockford and the Quad Cities mainly? Is that right?
Yeah, yeah, we don't have a respiratory program here locally, so a lot of it happens. There's a program in Rockford. There's a program in Peoria, which is the program that I went to.
Yeah.
And I think there used to be a program at Trinity in the Quad Cities, but I do not think that they're open anymore.
Yeah.
So Rockford or Peoria.
Yeah. So hey, if you're out there and you're thinking, you know, of someone who might be interested in being a respiratory therapist, please reach out to me or Ashley, and we want to talk to you a little bit.
Absolutely.
Yeah, for sure. Okay. Hey, Ashley, you got a great team.
Thank you.
Any shout outs you want to give to the folks on your team?
Yeah, to every single one of the respiratory therapists and the members of the sleep lab. During this pandemic, they have all been so amazing, and they adapt to change very rapidly. The sleep lab has had to change their process. Their patients now need to be COVID tested before they come into the lab, and that's been a change for the sleep lab. So the way that they have been able to adapt has been amazing to me. And our respiratory department is out of this world. They are so amazing,
Yeah.
and they really put their heart and soul into their job. They're very passionate.
Yeah. I echo that sentiment completely. They are a great group. They're hardworking. You see them when there's a sick patient around. You're going to see someone um, in a black pair of scrubs nearby because your team. That's what they do.
Yep. And for the record, we like to wear black. It's very slimmy.
Was that why you picked it? We'll get to this question in a second. Is that why your team picked it, Ashley?
I mean, that's why I voted for it. I don't know about anybody
Oh, okay. Well, now that's something else I learned today. That's did not know that. Okay, okay. So, uh, what was that question that just popped up, Matt? I want to make sure we get a chance to talk about that. So it says you work closely with COVID-19 patients. Were you worried about your exposure? Did you do anything special before heading home at the end of the day? Yeah, good question. How did your team deal with that, Ashley?
Yeah, so our team actually, they come in and they change their scrubs. So they don't wear the same scrubs into the hospital that they wear home. And we all in the respiratory department, actually, all of us now, went and purchased like surgical caps for our hair. So we stuff our hair up underneath the surgical caps so that we're well protected. And we wear the gowns and the gloves, and we have mask. We have these reusable masks, and some of us actually have ones that cover our eyes and our nose and mouth. It's like a scuba mask. And so I know I feel well protected, and I don't worry about bringing anything home to my family afterwards.
But when you first started, was it because I know I don't see tons of COVID patients, but I've seen a few, and that was you first it takes a while to kind of be like, okay, we're in here and it's happening. And how would you say at first how that was?
Yeah, at first I was a little more worried. When I would get home, the first thing I would do is go right to the shower, and I would tell my kids, "Don't hug me."
Right.
But now
Yeah.
I'm a little more relaxed because I
Okay.
know that the PPE is doing its job.
Yeah. Yeah. Yeah, but your team definitely they're putting themselves right there in harm's way with what's going on right now. So yeah,
Yeah.
once again, they do a great job.
Thank you.
So, um, anything else I didn't ask you, Ashley, that you thought, boy, I wish Bill would have asked me about this? Anything else? Thanks, Vicki. Yeah, Ashley's team does do a great job. Anything else that you thought I was going to ask you? You're like, I know Bill's going to ask me about this.
No, I was actually hoping you didn't have a lot of questions.
Ashley, you did a great job.
Thank you.
Thanks for the work that you and your team do, and great to have you here on Facebook Live broadcast.
Thank you, Dr. Bird.
I'm going to leave Ashley in the background. If you all have any other questions that pop to your minds, feel free to throw those out, and we'll get Ashley back on it. She can answer them. I just want to take a little bit of time here and talk about COVID and the status of COVID here in our community. And Matt, if there are any questions that have came in even before we started our broadcast, feel free to throw those up on the screen, and I'll try my best to answer them. I just wanted to, in terms of where we're at in the hospital, the number oh, thanks, Matt. So there's a number of cases that we've had in the county, and you see the 85 deaths. So confirmed case wise, yeah, we're getting close to confirmed case wise. We're getting probably close to that. What would that be? 7-8% range. And what we're learning, and I was reading this week, there were some numbers thrown out that they felt like 100 million Americans have had symptomatic or asymptomatic COVID. I don't know. We'll figure out more later. But suffice it to say that if it's 3989 in terms of the number of confirmed cases in our county, there have been a lot more unconfirmed cases and asymptomatic cases. So, oh yeah, okay. What role will CGH play in a COVID vaccine distribution plan? I think right now, I'm not sure. What we're doing behind the scenes. I'm gonna take a little drink. I'm getting a little something in my throat. Sorry. What we're doing behind the scenes is we have a team of folks who are discussing contingency plans of when the vaccine becomes available, how we're going to make sure that we get that to the folks that are supposed to get it as soon as possible and as rapidly as possible. But right now, there's a lot more. How do I say it? We have a lot less information than we would like to have about what exactly is going to go down. I've heard at first that it was going to go through the health department and they would disperse it out. Now I'm hearing maybe not. I think there's still some discussion at the national level about who are the tier one people that are supposed to get this. Is it going to be healthcare, clinical healthcare folks? Is it going to be healthcare folks and people in nursing facilities? So all that stuff is really, I think it's pretty fluid right now. We are really excited, and we're going to do our best once we get it to as many folks as quickly as we can. What preparations are you taking to store and distribute the COVID vaccine? Once again, still pretty fluid. We have folks working on contingency plans. We kind of in our minds have a space where we think we're going to give the vaccines, and we're working through the number our folks who will need the vaccines. Would you throw that up again? There was another question on there, Matt. We have to bring in freezers for storage. We do not think we're going to have to bring in freezers for storage from what we're understanding. And by the way, our folks are on regional calls with emergency management services and IDPH and all that kind of stuff on a regular basis, getting more information. But I think IDPH is still a little bit in the dark entirely in terms of how this is going to play out. I was reading something today that December 10th was the day that vaccines were going to be distributed or available. Here at the hospital, we have been given no definitive dates when the vaccine is going to be available to us to be able to give to our workers. I will share that it's our understanding right now that for our workers who have already had COVID, and this would go for if we were to start vaccinating nursing facilities as well. As I'm talking to you right here today, my understanding is if you've already had COVID, and you've had COVID within the past 90 days, that we probably wouldn't have you. We would not have you in that first tier of folks who would get a vaccination because of the immunity that you already have. So that's one of the things that we are hearing that is going to be the case. And so we're kind of thinking about that as we think about who at the hospital will need vaccines. At least will help us to conserve and get more vaccines to more people if we go by that understanding that people who already have COVID are immune for at least 90 days after that infection. So we think that'll be helpful. Yeah, so that's the other vaccine questions. I'm going to try my best to answer them. But that's kind of where we're at in terms of the vaccines right now. We've done 13,936 tests here at the hospital, and we've had 2387 that have been positive. So when Matt showed the Whiteside County numbers, it gives you a sense. I'd say about 2/3 of the positive cases, yeah, around in there, maybe a little less than 2/3 of the positive tests or cases have been done through the hospital. I am encouraged also that the number of hospitalized patients has gone down, and I'm so happy about that. It's such a good news for our community, and the community numbers so far seem to be trending down. I'm sure you all watch the percentages, and we were up to around 25% positive tests about 2 or 3 weeks ago, and I think yesterday I was thinking I think I saw 13%. So that's encouraging. I, I'm still cautiously optimistic that we're not going to see a Thanksgiving bump, but at this time next week, we will have a much clearer picture about that. Because as you do the math on that, if someone gets exposed on Thanksgiving or that weekend, then it takes about 2 to 7 days for the vast majority of those folks to get symptoms. And then if they then seek out care and get tested, you're talking another 2 or 3 days to get the test results back. So there's a lag from exposure to us it's showing up on our results. But so far, at least, it looks good. Like I said, I'll know more next week in terms of whether we're going to have a bit of a Thanksgiving bump. Oh, hi, Lisa. When someone has had COVID after recovering, when symptoms seem to come and go, how long does that normally last? Okay, so first question: when symptoms seem to come and go, how long does that normally last? Boy, Lisa, that can be anywhere from like a day or so to like I'm we have folks that will have cough, congestion, shortness of breath, loss of taste and smell. I'm sure you read all those things for months. And I forget what it's called. I think it's called the long COVID or something to the effect that people can last this COVID the symptoms that they have can last for quite a long time. It's very variable. And yeah, that's the best I can answer that question, Lisa. And can they be contagious again after recurring symptoms? So I guess, Lisa, I would say that I would be really comfortable that 90 days from when you started having symptoms and you tested and you were positive to 90 days after that period of time, you're not you're really, really, really unlikely to get someone else sick after you've done your isolation period of time. So I feel real comfortable during that 90-day window that if you have coughing or congestion or more shortness of breath or anything like that, that doesn't mean you're more infectious or that you're going to give you're going to give COVID to someone else. I think it's less clear after 90 days. The initial stuff I'm reading is probably we still aren't particularly infectious after 90 days for quite a while, but I think that the folks who are smarter than me at IDPH and CDC and other places are erring on the side of caution with that 90-day number. And I think that it's a good question you bring up, Lisa, because with the vaccine, that's going to be a question too. Is the vaccine a one and done kind of deal, or is there going to be a need, much like a flu vaccination, to redo that vaccine after a year or some period of time? Will patients need another booster? And time only will tell on that. And then the final question there was, I also have heard people say that you could be a carrier of the virus once you have had it. Is this correct? I don't think so. No. So once you've gone through your infectious period, and by the way, it sure seems like the vast majority of folks are most infectious, a couple days beforehand, up to about a week after, and then it really starts to go down. But we still have people isolated for 10 days for mild and moderate infections. But in terms of after that, you being someone who's going to spread that, no, I don't think that's not what the research is showing. Hi, Sue. Sue's asking, is it known yet if there are any adverse reactions if an asymptomatic carrier COVID patient receives the vaccination? Not that I'm aware of, Sue. Good question, because you're exactly right. There are going to be there are going to be some folks out there that even in the healthcare community that haven't felt poorly but may have acquired COVID, and I think so. I would say, Sue, that the plan is going to be, and granted, we still need to get more information from the CDC and Department of Public Health about this, and the vaccine manufacturers for that matter too. Oh, and the FDA about the bucket of patients that were asymptomatic. But my hunch is we're just going to go ahead and vaccinate those folks because typically with a vaccination program, the worst thing that happens with someone who gets vaccinated who's already had it is they already have antibodies, so maybe they produce a few more antibodies to the vaccination, but it doesn't typically hurt them at all. So I suspect, Sue, that if we're going to assume, unless you've had active symptoms and have tested positive, that we're going to assume that you didn't have it and we're going to vaccinate you. Good question, though. And while you're thinking of other questions, I just wanted to give another piece of what I think is pretty good news. So far, at least here in our community, we have not had, I think, any, but I'll just say we have not had, it's been like almost nothing in terms of flu cases of your usual seasonal flu. So that's been really encouraging. And I do think that having folks wearing masks has been really helpful as far as that goes. And it makes me wonder, Ashley talked about that, we're going to be probably doing how we do nebulizers and meteor dose inhalers differently in the future. It makes me wonder that when flu seasons happen in the future, are we going to be just wearing masks during that 1 month window, particularly in the healthcare area, and you go into a doctor's office or those type of places just to kind of keep the spread of that down. And I think we will. I guess we'll find out over time. Vicky, hi Vicky. Will you be COVID tested before you get the vaccine? That's not my plan, Vicky. And so if I'm told by the FDA or the vaccine manufacturer that that's what you have to do just to conserve vaccines and that type of stuff, I'll do it. But otherwise, no, I don't plan on getting tested prior to having the vaccine. For the same reason I was telling Sue that I just don't. Um, yeah, I don't think it's going to hurt for someone who's been positive to get a vaccine. Good questions. I'm about at the end of the information that I would try to think. If there's anything else going on here at the hospital. Like I said last week, I'm even more optimistic, cautiously, that. Oh, 1 second here. I'll answer that in just a second. I'm even more cautiously optimistic that about our cases going down. I sure hope that continues. It's a nice relief from the standpoint of our suffering patients, and I'm glad that we don't have as many patients who are struggling through this and needing to be hospitalized. And it's good for the staff too. So thank you. I mean, I know that folks have been doing a really good job out there. I see it. It seems to me like doing a much better job of wearing masks and doing the right stuff. And so thank you so much. The question was about infusions, monoclonal antibody infusions here at the hospital. So another good question. We do have a limited supply of bamlanivimab. How about that one for you? I think last week when I did this, I kind of butchered it, but I've gotten better at saying that name. So we have a limited supply of it's a monoclonal antibody. It's an infusion, and when you infuse the infusion goes in, and they're basically antibodies that kind of cause those spike proteins to not be able to get into our cells if we have COVID. So the niche of patients that is for is for patients who test COVID positive and are within the 10-day window of when they first started having symptoms. Anything beyond 10 days isn't a fit, and they have to be high risk. So they have to have certain things health wise that would make them a high risk for getting getting really sick with COVID. So what we're doing at the hospital with this right now is we're having our we get a list every day of patients who tested positive, and we're going through that list. And if you're someone who's high risk and on that list, um, that name is getting sent to your PCP, and then they are looking at that and having conversations with patients. And so we're beginning to have patients who are coming in here for that infusion process. The infusion is it's an emergency use authorization. It's not been officially approved in terms of the FDA. I know it's kind of weird wording to say it's been emergency use, but it's not approved. But that's how a lot of these COVID things are right now. And so we've begun to give those infusions to patients here at the hospital. We have a process in place to make sure to allow that to happen safely. Now, I don't know how long our supply is going to last, and but as long as we have it, we're going to give it. Just feel like that gives patients another opportunity to get better. I've heard folks who've had it and they feel better shortly thereafter. Granted, that doesn't mean that that doesn't mean that that's going to be a case for everyone, or that even that was why they feel better quicker. And some people just get better. So anyhow, it's something that we're using here at the hospital, and we'll use it until our supply runs out. So if you're someone who tests positive and you wonder about, am I a candidate for that? We'll put the name up on Facebook, the name of the medication. It's bamlanivimab. And if you think you might be, you look up the product information and you're interested in that, you can call your own primary care doc and kind of talk with them about that and have a conversation and see if that might be a good fit for you or not. While supplies are Why supplies last. Good question. All right. I as I'm about 40 minutes into this, you've probably heard enough of me by now for the week. So I sure thank all of you for listening and for sharing this with others in the community and outside the community. Hopefully, we've given you some information that will be helpful as you go forward. And gosh, the future is looking better. I'm really encouraged by it. Everybody, thank you. Keep up the good work. Look forward to being here next week and having a conversation. And until then, stay safe, and we'll see you next week.